My name is Ryan Holleman. This is my final presentation for the Comparative Effectiveness in Athletic Training course in the DAT program at AT Steele University. This particular project is going to look at patients requiring a meniscectomy procedure, and we will compare two interventions that may be utilized in the rehabilitation process. First being low intensity blood flow restriction training, or BFR. The second intervention being high intensity resistance training. When looking at meniscus injury, we will start with some background and epidemiological data. There are over 1 million knee arthroscopy procedures performed per year in the United States, which makes this the most common orthopedic surgery done per year. Of those 1 million knee arthroscopies, over half of them actually include injury to the meniscus. The incidence rate of meniscus is estimated at 60 to 70 people per 100,000 will sustain a meniscus injury. When looking to treat meniscus injury, there are typically two treatment options that the patient and clinician may choose to utilize. The first being conservative management or rehabilitation, which is non-surgical. The second option is surgical intervention, which may include a meniscectomy or a meniscus repair. The repair is done where the torn meniscus is actually sewed and stitched back together and allowed time to heal. The meniscectomy is a dissection of the torn part of the meniscus and is removed, which does not require any healing to the meniscus. Regardless of the intervention that is chosen, strengthening is going to be one of the key components of the rehabilitation process. There's been some literature that's shown quadricep deficits up to 4 years following surgical procedures. So with that, we want to make sure that we address the strength loss, atrophy, and functional limitations that may be taken on by the patient following a meniscectomy. First option will be high-intensity resistance training. This is the gold standard when it comes to muscle strength and muscle hypertrophy. So according to the American College of Sports Medicine, to improve strength and hypertrophy, the patient needs 60 to 85% of their 1 rep max to be completed 2 to 3 times per week. That 1 rep max is usually done 3 to 4 sets at anywhere from 4 to 6 repetitions per set. Second option that we'll compare is blood flow restriction training, or BFR. BFR is fairly new to the athletic training setting. It's recently started to grow in popularity. I think this is primarily due to the accessibility of the BFR units. Production has been streamlined, and they have now been able to offer these at a decreased cost that's a little bit more effective for those of us in the athletic training setting. BFR uses a tourniquet that's placed on a proximal limb, whether on the upper thigh or the upper arm at the humerus. The tourniquet limits arterial inflow while also blocking venous outflow, which creates essentially a pooling effect of the blood in the muscle. Some of the benefits that may be seen and have been reviewed in the literature are increased hypertrophy, increased strength, increased VO2 max, decreased delayed onset muscle soreness, or DOMS, and the release of a growth hormone. Noting the lack of knowledge for blood flow restriction training and its minimal use in the athletic training setting, the following clinical question has been proposed. In patients requiring a meniscectomy procedure, how does low-intensity BFR training compare with high-intensity resistance training to improve patient function, increase strength and hypertrophy of the quadriceps? We've noted 3 outcome variables that we'll utilize for this particular project. The first being patient function. This will be measured with the lower extremity functional scale. This is a 20-question questionnaire that's scored from 0 to 80, with the MCID being noted at 9 points. For strength, we'll look at the 1 rep max, utilizing a leg extension machine, essentially to try to isolate the quadriceps muscle group. And to measure hypertrophy as an outcome variable, we will use girth measurements of the quadriceps. We will take these bilaterally. Proposal for this project is a point-of-care clinical trial. The reason this is chosen was because of the strengths and try to help balance some of the limitations that the randomized controlled trials and the observational study design has. So essentially, we're going to get the best of both worlds when looking at those um, procedures. So for this particular project, the population group is going to be targeted to those patients requiring a meniscectomy. Inclusion and exclusion criteria, some of the highlights will be patients will be included only if they have an isolated meniscus tear. We will eliminate anyone who's had previous lower extremity injury of the involved limb previously over a 2-year span. Any previous surgery on the involved limb, and we want to make sure and ensure that no contraindications to actually utilizing the blood flow restriction units and the tourniquet are noted. That will be an automatic exclusion. When looking at the stakeholders for this project, we've looked at the framework that was proposed by Concanon, the 7 Ps, which include patients and the public, providers, purchasers, payers, policymakers, product makers, and principal investigators. So for our particular project, the patients and the public are those that are requiring meniscus surgery, and we've also included future patients because of the effect that this research may have on anyone in the future that may actually have to go through this procedure. Providers will be any of those that are actually working with the patients. Athletic trainers, physical therapists, and even orthopedic surgeons have been included as they're one conducting the procedure and usually the ones that are also designing the rehabilitation protocols. Purchasers will be the patients or their employer, potentially an educational institute if they're a collegiate athlete. Payers for this will be insurance companies or the patient themselves if they are uninsured or self-pay option. Policymakers will be the athletic training clinic or for this particular project, the Owens Recovery Science Group. They're the ones that offer the certification course in blood flow restriction training that the principal investigators are using. Product makers will be Delphi PTS. They're the ones that make the blood flow restriction unit. And the principal investigators will be myself and the research team. When we're looking at a point of care clinical trial, the electronic medical record is really the key in making a point of care clinical trial succeed. So for this particular case, we're going to use the EMR to flag any patient that is enrolled with a meniscus injury. A questionnaire will automatically pop up that is used to screen patients to see if they qualify for the study. It'll ask them things such as medical history. If a patient meets all the criteria, they'll have an option to enroll. They'll then have to sign a waiver and consent forms. Once they're enrolled, we'll collect other baseline data, which will include some vital signs, blood pressure and pulse. We'll also take the girth measurements of both quadriceps and look at a 1-rep max of the uninvolved extremity. The EMR is important for us because we're going to be able to assign our patients using Bayesian statistical methods. And the reason I like this is it's going to give us some adaptability and it's going to tailor the preference to the group that is assigned based on the outcomes that we're having. So this is essentially the idea behind patient-centered care and evidence-based practice. So again, that's why the point of care clinical trial was chosen. Patients will be assigned to one of 2 groups. The first is going to be the BFR protocol. Here's a sample protocol that a patient may be enrolled in over an 8-week period. The blacked out portions are those that the patient will not do during those particular weeks. When they're using the BFR protocol, they'll do their exercises. Using the tourniquet, it'll be set at an 80% limb occlusion pressure. 4 sets will be conducted. The first will be 30 reps. The following 3 will be 15 reps. You'll start with body weight and progress to a maximum of 30% of the 1-rep max that's taken on the baseline of the uninvolved leg. Weight will be progressed up to that 30% 1-rep max once the patient's able to complete all sets and reps for that particular exercise. And the protocol will be performed under clinician supervision. High intensity resistance training protocol, this will be group 2. They will have the same exact exercises. The difference will be in the reps and sets and the amount of weight that will be utilized. 4 sets at 5 reps will be the standard. And this will be progressed up to a maximum of 80% of the 1-rep max on the uninvolved leg. Significance of this study is ideally to close the gap, whether it be through knowledge and practice, especially with the blood flow restriction units being fairly um, not new, but they're really gaining popularity now in the athletic training setting. So more research and data needs to be collected to make this a significant therapeutic modality to use with our patients. Another area of significance would be the ability to improve patient outcomes. We may have the opportunity to improve return times, get them back to sport faster, get them back to activities of daily living faster. We may improve function at a better rate than the gold standard. And so that really is the significance of this project. There's a lot of unknowns, so the ability to investigate that. And another important area of significance that I noted was the ability to kind of translate this to other injuries, or the ability to actually translate it to the strength and conditioning world. For the particular procedure that was chosen of a meniscectomy, we don't really have a lot of healing times to respect because there was nothing that was repaired. So we're primarily for this protocol just targeting muscle groups. So the strength training world may actually benefit from this data. Feasibility. To make this study feasible on the front end, we chose the point of care clinical trial. So this is going to allow us to conduct routine patient care in our natural setting and hopefully decrease some of the costs that might be incurred if this were a randomized controlled trial design where we're essentially trying to control a lot of things that are out. Some of the challenges that we note for this, the first is going to be cost, primarily with the equipment. Most athletic training clinics are not going to have the blood flow restriction units available, so they're going to have to go through the cost of buying those units as well as taking the certification to actually be able to use those units. So BFR certification, as you can see, is also noted as a challenge. Probably the most foreseen challenge would be the electronic medical record. So the actual cost of an EMR is fairly high, especially to do a lot of the capability that will be needed to conduct a point of care clinical trial. And the functionality, the ability for the EMR to automatically flag patients, conduct a lot of our patient outcome data, that functionality is not typically seen in your standard athletic training EMR. Thank you for listening, and I look forward to hearing everyone's feedback, and thank everyone for a great semester.